introduction. So it's my honor to introduce Dr. Howa Yeung, who is an assistant professor of dermatology at Emory University School of Medicine. He earned his MD from New York University with AOA honors. He trained at Emory for dermatology residency and completed an MSc in clinical research from Emory after residency. His current research is supported by the National Institute of Arthritis, Musculoskeletal, and Skin Disease, and aims to improve prevention, treatment, and outcomes of skin disease that disproportionately affect sexual and gender minority populations, such as acne in transgender patients. We're really excited to have him here with us today, and without further ado, over to Dr. Yeung.
Thank you, everyone, for the invitation, and thank you for the lovely introduction. I'm Howa Yeung. As I said, I'm an assistant professor of dermatology at Emory. And today we're going to talk about skin health in transgender and gender diverse persons, current disparities, and future equity. These are my disclosures. I will talk about off-label use of medications, and these are some of my funding mechanisms. Today's learning objectives are to describe common skin concerns that disproportionately affect transgender and gender diverse persons in the context of gender-affirming care, to discuss structural mediators of skin health disparities that are received by transgender persons, and to identify strategies that address dermatologic care equity for trans people. So to start, I always like to actually hear from trans people. And so I'm going to play a short video that you hear about trans folks, about what they feel like their care is like and what care they actually want.
My name is Rose. I'm a transgender girl. I was born a boy, but I always knew that I was a girl.
I'm Devon. I'm a trans male. I was born female, and I live now as a male. I was 3. I decided that I was going to grow up and be a father and marry Janet Jackson.
She would write letters to Santa Claus, to the Tooth Fairy. When would I be turned into a girl? Could you turn me into a girl?
I'm Jay. I'm a non-binary trans person. That means that I'm not a man, nor am I a woman. I was raised as a girl, but when I learned about non-binary gender identities, it was like a whole new world had opened up for me.
My name is Ronnie, and my sister Ellie is transgender.
Ellie told us on her 4th birthday that she was a girl in her heart and her brain. And I said, "You're my favorite princess boy." And what did you say, Ellie?
No, I'm a princess girl.
My struggling point was this had to be a phase.
The reality is acceptance takes a while.
I was terrified of coming out. I was afraid of losing friends, family, loved ones. I was afraid of this discrimination and potential violence I could face.
I was so terrified that I wanted to die. Got threatening letters. One of the quotes said, "Do us a favor, Paula, put that gun back up to your head and finish the job."
I'm scared as a dad for her safety, whether society will be as accepting as her family and her friends are.
I feel embarrassed and unsafe when people out me to other people.
If there isn't a gender neutral bathroom available, when there are only men's and women's bathrooms, I have to make a decision about how I look that day and whether there's more risk for me going into the men's room or the women's room.
I was chased by 4 people in the metro for being transgender.
I have been denied healthcare. I have been gawked at. I've been humiliated. I have been physically assaulted several times when using the bathroom.
Seeing her face the first time we let her wear a dress outside of the house. pretty special.
You're different. That's okay. Just keep on being yourself.
Support means listening, maybe not understanding, but just listening and being there for me.
Pushing back on jokes or offensive comments at the expense of transgender people.
The easiest way to support transgender people is to follow their lead.
Supporting transgender people means letting them be who they are.
I want to be trans because I want to be myself.
I'm proud to be trans because I think life is too short to be anything besides what you are. This is who I am.
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 So now that we've heard a little bit about what trans folks in the US have expressed their needs are, let me first by acknowledging that most of our transgender health study are really based in North America, South America, and some in Asia. And there are still a lot of knowledge gaps in terms of what trans people need and want and what their healthcare is like and what their health needs need to be addressed are like. And so this is just one study from the Lancet showing that most of the distribution of the current studies about transgender health is US based, which is where I am based. And so this is going to be the majority focus of our talk. But we recognize that there's more global needs to address knowledge gap about what transgender healthcare is like. In the United States, there are more and more LGBTQ identification among adults. 20% of Generation Z now identify as LGBTQ. 10% of millennials like myself identify as LGBTQ. So this is something that we definitely see more and more. As was mentioned, in 2021, 7.1% of all US adults identify as LGBTQ. Among them, 0.7% or more than 1.6 million US adults identify as transgender. A third of whom do not identify exclusively male or female, or known as non-binary. And a subset, 14%, identify as gender non-conforming. One epidemiologic figure that I would like for us to think about is 0.7% of US adults identify as transgender. How many times in US medical school have we learned about diabetes? I can't imagine anyone graduating from medical school not learning about how to manage insulin or what are the complications of insulin management and complications of diabetes mellitus. However, many of us graduate in medical school learning nothing about gender-affirming hormone and surgical care. So it's really important for us to use this chance to learn more about things that affect a substantial proportion of our population. The first thing to really think about is what are some important terms in sex and gender that we should really think about. First, sex assigned at birth. For example, me, Howa Yeung, I was born, as a boy. When I was born, my doctor and my mom took a look downstairs and they're like, it's a boy. Most of that is really assigned by another person based on the appearance of the external genital anatomy. Now, I also identify as a man. So my gendered identity is a man, which is congruent with my male sex assigned at birth. And so that's known as cisgender. Some people have a gender identity that differ from their sex assigned at birth. For example, a transgender man might be female assigned at birth, and they identify as man. A transgender woman might be male assigned at birth and identify as a woman. Gender expression. This is what I'm wearing today, and this is how I'm appearing to you today. I might be wearing a suit. I might be going out to a club, and those might be different gender expression that might look different at any different given time. Sexual orientation. I identify as a gay man, and I have a male partner. But sexual orientation might also be different from sexual behavior, which is about who do you have sex with and how. For transgender folks, some folks experience something called gender incongruence or gender dysphoria. It is defined by a marked incongruence between someone's sex assigned at birth and their experience or expressed gender. Sometimes that is associated with clinically significant distress or functional impairment lasting greater than 6 months, and that for which many will seek treatment. It's really important to note that gender incongruence is not categorized as a mental health or behavioral disorder in ICD-11, and is considered a condition related to sexual health. For some trans folks who are experiencing gender incongruence, they might seek gender affirmation or transitioning. And that could involve changing how you express yourself, wearing clothes, or behaving in a way that express in the gender that you identify with. They might change their legal documentation. They might modify how they speak or how they communicate with another person. Some folks would also seek medical and surgical care, such as gender-affirming hormone surgery, as well as surgical procedures. It is important to note that trans people are not a single population. This is a large survey of LGBTQ folks in the United States, and particularly of the transgender folks. A third identify as man, a third identify as women, and a third identify as non-binary. Their sexual orientation is really all over the map, and we should not assume someone's sexual orientation based on their gender identity. Transgender people have partners. Transgender people have children, and they might even have young children. Many transgender people have experienced bullying when they were children, and have experienced various forms of abuse as a child. Many can be related to their trans experience. And many continue to experience victimization as an adult due to the discrimination that unfortunately our society, in which transphobia remains very prevalent. Some folks may receive less courtesy in everyday life. They might worry about being judged. They might receive poor service in everyday life. They might they might experience discrimination at work or when trying to find housing. And many report that they can't make ends meet, they're alone, and they have constraints with their relationships. And that's in the context of all of those stressors, many experience worse health outcomes. In fact, 42% of trans people have attempted suicide in their lifetime. So these are really important negative health outcomes that we're trying to address. And as dermatologists, we'll talk about the role that we can play to improve the healthcare and health outcomes of trans folks. It is also important to note that HIV is highly prevalent, particularly among transgender women, and racial and ethnic disparities also exist among transgender women living with HIV. For example, the prevalence of HIV is actually as high as 62% among Black and African American transgender women, and 35% among Hispanic and Latina transgender women. And again, it's really not just about this population, but it's about the society and the environment in which transgender people are living in, working in, and the everyday stress that people are experiencing related to victimization, rejection, and the stress that our society unfortunately places people in. And so there's more and more research framework that really understands health disparity, not just about this population, but about the environmental factors, the interpersonal factors, the community factors, and the societal factors that really influence the health of trans people. And as doctors, we think that we're always helping, but we might not always be. In fact, 1/4 of trans people have reported they were refused necessary healthcare by their healthcare providers. 20% of trans people said that their healthcare professional blamed them for their health status. And people have even reported experiencing abusive language as well as physical abuse in healthcare setting. And guess what? This is not a far-fetched idea. Just a couple of years ago, iPledge, which we used to prescribe isotretinoin to many of our folks, systematically excluded transgender folks from participating in iPledge and in receiving isotretinoin care. So we really need to reflect as dermatologists, in what way are we helping to deliver gender-affirming care, and in what way our system is really creating barriers. Moreover, while many of us understand that this is important, very few dermatology residency actually have topics, educational topics related to trans healthcare. In fact, 1 in 5 had 0 topic even relevant to LGBTQ patients in their curricula in one survey study of US dermatology residency program. So, as was said, there's a lot of barriers to even provider education to understand how we can best deliver care for our trans patient. So today we're going to take some time to go over a couple of cases of our trans patients' care to think about how we can deliver our care a little bit better. And just as a disclaimer, the names and details of these particular cases were changed to protect patient confidentiality. So this is our first case, Liam. Liam is a 14-year-old transgender boy who was assigned female at birth, and he was referred to dermatology by pediatric endocrinology for acne for the past 9 months. He has painful lesions affecting his face and trunk, and he tried multiple over-the-counter treatment without improvement. Liam's first experience with gender dysphoria started at age 5 to 6. And at age 13, he started wearing male clothes and requested to be addressed as Liam with he, him pronouns, and mentioned gender dysphoria in his primary care doctor and mental health settings. His parents and extended family members were very supportive, and they're adjusting well to his transition. His dysphoria mostly stems from having breast development, and so he wears a binder, as well as menstrual cycle. His menarche started at age 11. And so by the age of 13, he was started on testosterone cypionate 50 milligrams every other day injection, along with oral norethindrome 5 milligram aimed to cease and cease. And eventually that was gradually increased to 100 milligrams of testosterone cypionate every other week, as well as oral norethindrome 10 milligrams. He has no other past medical or surgical history. He denies any depression or suicidal ideation, and he's very interested in receiving top surgery to address the gender dysphoria that stems from breast development. He's a high school freshman, he's not sexually active, and he has a family history of anxiety. So this is his initial presentation, and you can see that he has severe acne, multiple erythematous papule pustules, as well as nodules on his bilateral cheeks. And you can see numerous erythematous papule pustules on the back as well. We did not show his chest because he had significant dysphoria related to examination of his chest. So thinking about the effect of testosterone on the skin, we know that development of acne occurs within the first 6 months of testosterone initiation. Now, this is an adaptation of the current WPATH guidelines, which somehow seems to think that acne really completes its effect within the first 1 to 2 years. However, in my experience, that has not really come true, and many of our patients continue to experience acne after the first 2 years of testosterone initiation. Now, when I was in residency, how are we supposed to address steroid-induced acne? And in, say, bodybuilders, we often tell people just to stop using the anabolic steroids or testosterone. However, in the context of gender-affirming care, that is generally not realistic. And that ignores the fact that the gender-affirming testosterone therapy is rendering really important positive mental health outcome for the patient. And so we will go back to our AAD acne guidelines in terms of thinking about how do we treat our patients with mild, moderate, and severe acne? But in our trans patient, there are specific considerations that we need to think about in addition to what the guidelines say. For example, is the testosterone dose optimized? Should we think about the every other week dosing and whether the serum level of testosterone is appropriate? Second, he's wearing a binder, which is, some people wear a binder, which is depicted on the right here, which is something that people wear to decrease the appearance of breast development and decrease associated gender dysphoria from chest appearance, and whether that can be part of the trigger for acne development. And then for someone with severe acne, oftentimes we think of using isotretinoin for treatment. If Liam has planned for top surgery, would isotretinoin initiation be timed correctly so that we don't want to necessarily delay his gender-affirming surgery plan? What are other specific considerations? For example, if you would like to treat someone with long-term oral antibiotics, when is the stopping point? This patient is most likely going to continue on testosterone for a very, very long time, if not lifelong. What are some issues about antibiotic stewardship that we need to consider? What about contraceptives and anti-androgens? For transgender men, generally estrogen-containing combined oral contraceptives are not used as the main form of acne treatment in trans men. And in our patient, he's using a progestin-containing oral contraceptive, which can worsen acne, although it might be able to help us facilitate isotretinoin initiation, as well as thinking about would even estrogen-containing oral contraceptive be acceptable to our patients, especially when they're trying to achieve further masculinizing effect from their testosterone therapy. Lastly, for our patient who is probably considering isotretinoin, it's really important for us to have an informed consent about teratogenicity and contraceptive discussion. Long-term testosterone use, even when it stops menses, is not a reliable form of contraception. So it's really important for us to think about how can we facilitate contraception in this setting. Secondly, multidisciplinary care is really important given the association between isotretinoin use and worsening depression and suicidality in some study, which has not been really borne out in large population-based studies. And lastly, coordination with surgical care is really important because the last thing we want to do is to affect someone's gender-affirming surgery plans. As many of you know, iPledge has really moved onto a gender-neutral model. So the focus is now on whether the patient can get pregnant or not. In our patient, the main thing that we have to start off with is to assess his gender identity and sex assigned at birth. Liam is assigned female at birth and is a transgender man. And then we will conduct an anatomic inventory. Because he still has a functional uterus and ovaries, contraceptive must be considered, and he must be registered as a patient who can get pregnant, which requires 2 forms of contraception or abstinence as per iPledge. It's also important to review the various primary forms of contraception that are appropriate for iPledge in transgender men. I think it is one of the common misconceptions that you cannot use any hormonal contraception. That is not true. For example, hormonal implant and hormone IUD might actually be preferred by some folks because if they are still having continued menstrual periods despite being on testosterone, using hormonal implant and IUD can actually reduce menstrual bleeding and reduce menses-related dysphoria. So discussing contraception with a gender affirming reproductive health specialists can be really, really helpful. So in our patient, we assessed Liam's sex assigned at birth, assigned female at birth. His gender identity, he's a trans man on testosterone, with a plan for future surgery for his top surgery, and he is abstinent with any sperm producing partner. So in conjunction with everything that we talked about, we had a multidisciplinary planning going on where we talked about informed consent, where we talked about all the contraceptives that we need to do, where we talked about adverse event management, and we decided to have a plan together on how to address his particular problem. First of all, we started him on doxycycline, benzoyl peroxide, and tretinoin, and he has substantial improvement in his acne of the face and chest and back. However, we were doing this so that we can have him complete his top surgery, which he was able to complete very shortly afterwards. And at that point, he still has moderate acne going on his face, chest, and back after healing from his top surgery. And then we were able to transition to isotretinoin. And after transitioning to isotretinoin, he started to have much more dramatic response. And we were also able to taper off his norethindrone as his intramuscular testosterone dose titrated up. And at that point, his acne was almost clear after 5 months of isotretinoin treatment. And thinking about additional systemic barriers, at that point, he had his legal name officially changed to Liam. But at that point, because he had then new insurance plan under his new name, Liam, and that required a new prior authorization and delayed his treatment further. So as you can see, acne treatment in transgender folks can be quite complicated, but at the same time, we're able to really make a huge difference in our patients' lives. The World Professional Association of Transgender Health Standard of Care version 8 now emphasize that acne is one of the expected physical change induced by sex hormone treatment, particularly in testosterone-based treatment. And so it's really important for us to educate our endocrine colleague that this is something that's treatable and that this is something that dermatologists are really good at, and we can actually make a huge difference in our patients' lives. A second case, this is Latisha. Latisha is a 25-year-old transgender woman. She is assigned male at birth and uses she, her pronoun, who presents with unwanted hair growth and bumps on her face and neck for multiple years. She shaves 1 to 2 times a week despite after starting hormone therapy, and these lesions are painful and causing scars. She uses an over-the-counter aftershave, and still that continued to be bothersome. She always knew that something was different about herself, and she wanted to play with dolls and wear girls' clothing as a child. As she got older, she expressed more femininely, got her nails done, had longer hair, wore feminine clothes. She wanted a slower transition because of family concerns. Her parents are not supportive of her transition, but her siblings are. So she thought about starting hormone therapy for quite a while, and at the age of 23, she started with estradiol valerate intramuscular injection, 10 milligrams every other day, as well as oral spironolactone, 100 milligrams daily. And she's been on that regimen for the past 2 years. She's living with HIV, and she's treated using Descovy and Tivicay. And this is what her face looks like. And you can see numerous perifollicular papules as well as pustules on the bilateral lower cheeks and on the neck associated with the facial hair distribution. So reviewing the effect of estrogen and anti-androgen on the skin. Estrogen and anti-androgen will soften the skin, decrease oil production, decrease acne, and slow hair growth. And that can take somewhere between 6 to 12 months to start the effect, and completion of effect might take quite a long time. In fact, one a cohort study of transgender women showed that after 1 year of feminizing hormone therapy, there's a decrease of 44% of facial hair density, which is great, which is helpful in terms of decreasing one's need of shaving. However, that also means that 56% of the facial hair remains. And in fact, in our experience, most transgender women, even on adequate feminizing hormone therapy regimen, will continue to need facial hair shaving unless they receive some sort of permanent hair removal. It is important to note that permanent hair removal is a medically necessary gender-affirming procedure aimed to reduce associated gender dysphoria. As was said, most transgender women still require shaving of facial hair despite adequate hormone therapy. Treatment could include topical eflornithine, which unfortunately is no longer available in the United States, electrolysis, as well as laser hair removal. And just to reiterate, the WPATH position statement has affirmed and reaffirmed that facial hair removal is a medically necessary procedure. The newest world WPATH standard of care, as has been said before, reiterate that we recommend healthcare professionals offer hair removal as part of gender affirmation or as part of preoperative preparation process. So why is this medically necessary? I want us to read some of the anecdotes and stories from trans people so that we have a better understanding of why this is really about a medical indication. Hair removal for trans women isn't just about vanity or feeling gender stigmatized. It is an issue of personal safety. Having a 5 o'clock shadow or long, white, spiky hair glinting in the sunlight signals to the world that your body is in flux. Most days I accept I can get past it, but occasionally the stubble floors me. I want to curl up in a ball and stay on the train, going back and forth all day long until the night falls and it feels safe to be on the street. I know there's an element of body dysmorphia here, but I'm also self-caring enough to know that it comes from a place of feeling vulnerable, not just from vanity. As was discussed before, many transgender people experience victimization from violence and feel unsafe living in our society. And one of my favorite studies that has been done was this study from the 2015 US Transgender Survey. And it showed that in this very large survey of transgender people, 90% of transgender women either want or have had permanent hair removal procedures. And comparing those who have had hair removal procedures versus those who did not have hair removal procedures, there's a 38% decreased odds of having severe psychological distress in the past month. There is a 28% decreased odds of having suicidal ideation in the past year, and there is a 26% decreased odds in suicidal attempt in the past year. Now, I understand that this is a cross-sectional study. This is not a randomized controlled trial. But if these figures hold up in larger observational studies and or randomized controlled trial, this would be some of the most impactful thing that we can do as a dermatologist to reduce psychological distress and to reduce suicidal ideation for our patients. So third and last case about Laverne. Laverne is a 41-year-old transgender woman assigned male at birth, and she presents with painful plaques on her bilateral buttocks for many years. Many years ago, she traveled to a hotel in North Carolina to have silicone injected to her buttocks. Areas have since hardened. Sometimes there's swelling, there's no swelling today, but occasionally she had very severe pain that associates with difficulty walking. Like our last patient, she also lives with HIV and she's being treated with the Genvoya. So here's a picture of Laverne. There are these large indurated plaques that are very, very indurated, very severely indurated. They're hard as concrete on bilateral buttocks and lateral thighs. Silicone and other illicit fillers are actually very commonly used in the trans community. In one study of transgender women in San Francisco, showing that 1 out of 6 trans women have received these illicit filler injections, mostly on the buttocks, but also sometimes on the hips, breasts, face, or calves, oftentimes from unlicensed and low-cost so-called silicone pumpers. And the content of these silicone injections vary in terms of their ingredients. And that can range from food or industrial grade silicone to paraffin, to petroleum jelly, to beeswax, to various oils, even reports of tire sealant, cement glue, and transmission fluid. And it can range from small amount, like several ounces, to very large amount, like 8 liters. And severe complications have resulted, both acute and chronic, like development of foreign body granulomas, infection, including bacterial and atypical mycobacterial infection, bleeding, pain, scarring, ulceration, fistula, disfiguration, development of lymphedema in the area, as well as distally. The silicone could migrate and cause embolism, particularly to the lungs, and development of sepsis, hypersensitivity, pneumonitis, and death have resulted in many famous cases. The FDA have in 2021 finally issued a warning against injectable silicone and dermal fillers for large-scale body contouring and enhancement. So why would people do this? So I'm going to read some anecdotes from this NPR article about, for trans women, silicone pumping can be a blessing and a curse. It's about surviving. And I'm not going to lie to you, she said, her voice breaking. In my new body, I felt so beautiful. I felt so together. I felt like I fit in. And even though I was one of the most educated people in my circle, I still went ahead and gave in. The more passable your body was, the less bullying you'd get, the more chances of you getting a regular job at a regular place without somebody clocking you. There were all these stipulations that came along with having this done in order for you to feel like you're gonna have a better life. From looking better, people telling you that you look better, being able to stop doing survival sex work and getting a job. And here's one case of a patient who developed painful indurated plaques that arose in the areas of injection years to decades after the injection. And you can see the associated lymphatic lymphedema. You can see the granulomatous inflammation that are associated on the side right there. You can see the developments of varicose vein in the area, along with some post-inflammatory pigmentation, pigmentary alteration. And some people can also develop infection and abscesses. And some cases have been reported with mycobacterial tuberculosis infection, as well as atypical mycobacterial infections. And so in our particular patient, we initially tried intralesional triamcinolone injection because she was being treated with Genvoya, which contains cobicistat, a cytochrome P450 inhibitor. We actually discussed with her infectious disease doctor to switch to a regimen that does not contain a booster to avoid drug-drug interaction. And that really helped with some of the reduction of the indurated plaques, as well as a lot of the pain that was associated with these plaques. And then she was maintained on hydroxychloroquine for longer-term treatment to avoid the long-term systemic side effects of systemic steroids. And that she was well maintained for about a couple of years, but then afterwards she actually developed ischemic skin ulcers in the area and required further evaluation and treatment. Here's the friend that she went to North Carolina with to get the injection. Unfortunately, she had a more complicated course. This patient, also a patient of mine, developed pulmonary hypertension from chronic thromboembolism related to her silicone and developed heart failure in the setting of silicone migration. Initially, she was also maintained with hydroxychloroquine with decent pain control, but she developed QTc prolongation and then switched to minocycline. But then that was not adequately treating her her silicone granulomas, and she presented in the hospital with symptomatic hypercalcemia, likely due to her silicone granulomas acting like sarcoidal granulomas. And unfortunately, this patient ultimately passed away from her heart failure. So guess what? If we're not providing gender affirming care for our patients, patients are going to seek these cares from people who may not know how to do it safely and efficaciously. But guess what? Dermatologists are actually really good at providing body contouring as well as safe facial procedures, aesthetic procedures. For example, dermatologists are able to flatten the eyebrows, increase eyebrow projections, widen malar prominences, volumize lower lips, and do chin augmentation to make a face look more masculine. And for example, here's one patient who had his acne treated in the context of his testosterone, gender affirming testosterone treated, but also got fillers to volumize the cheeks as well as the jawline to make his face more masculine appearing. And similarly, we're also very good with doing facial procedures to feminize someone's facial expression by arching their eyebrows, reducing glabellar fullness, reducing their masseter and mentalis muscle size. We can also volumize their upper lips, their cheeks. And here is a patient that received masseter reduction, as well as some filler to widen the temples and the cheeks and to lift the mouth corner, as well as volumize the lips. And very happy with the more feminine appearing facial structures. And here are some more examples of lip fillers to help, as well as masseter reductions to really help feminize the face. So dermatologists have really important roles to deliver gender affirming care and to assist in treating any complication in gender affirming hormone and surgical therapies. But ultimately, for us to treat trans patients, you have to know who they are. And you have to let trans folks take lead in terms of allowing them to tell you who they are and creating a space for people to feel safe to tell you who they are. A lot of people ask me, so how would I know this patient is trans? In the United States, all electronic medical records have the capacity to record someone's gender identity, sex assigned at birth, and sexual orientation. So if those things are routinely captured in your intake form, then that will be very easy and avoids any awkward conversations that one might have, as well as allow your patients to know that you care about their gender identity, you care about the sexual orientation, and you care about knowing who they are. And there are many ways for us to have a conversation about people's gender identity and sexual orientation in a neutral, inclusive, and respectful way. Normalizing taking a sexual history, discussing confidentiality and documentation, and using inclusive and patient-preferred language are going to be very, very important. Having cues to show that you are creating a welcoming environment, that you are a safe space, that you know more about pronouns, that you allow your patients to use whatever bathroom that they prefer to use, and having non-discriminatory policies, non-discrimination policies obviously put visible in your clinic would be very important. Some of the best practice in caring for our sexual gender minority patients include using inclusive and patient-preferred language, maintaining cultural humility, respect, and willingness to learn, discussing specific challenges and skin health disparities with them, and creating a welcoming environment. And so I hope we get to review some of the structural barriers that are really affecting our patients, as well as showing you how dermatologists can play a role in terms of addressing some of our trans patients' skin health needs. I obviously cannot go through all of the nuances about LGBTQ dermatology today, but I encourage all of us to attend the LGBTQ Sexual and Gender Minority Health Symposium that is available every year at the AAD meeting, as well as join the LGBTQ Derm expert resource group if you're interested in learning more. And to wrap up, I want to acknowledge my wonderful colleagues at Emory and Grady Transgender Clinic. These are a group of very wonderful, caring, and inclusive set of doctors from numerous specialties who are doing amazing care caring for our patients. And I just want to conclude that it is really a privilege and an honor to take care of these patients. They are one of the joy of my dermatology career. And these are my mentors and my lab members who I would acknowledge. And thank you all for your attention. And I'm happy to answer any questions from you. Thank you.
Thank you so much, Dr. Yeung, for sharing insights on caring for transgender patients and really highlighting the important considerations for dermatologists, especially regarding gender-affirming care and skin diseases. It was really insightful. Thank you so much. We've got about 10 minutes for questions. So if anyone has any, please feel free to post in the chat. I can start off actually. I thought it was really interesting that you mentioned a lot about the gender affirming care and how some of those can contribute to, say, acne or other skin problems that transgender persons face. I was wondering whether in your experience, transgender persons experience any other skin disease more than cisgender folks, or is it just the same across the board? Yeah, any insights?
First, I would love to answer your question, but there's so little research that focuses on transgender health. So I think the first thing that we need to do is even start the conversation and start to collect this information. Believe it or not, most people's in their dermatology offices don't even collect people's gender identity and whether someone is trans or not. And so without that information, I can never address your question. So I really appreciate the question and I would love the opportunity to address that question, first of all. There are emerging studies that look at different types of skin problems that can arise, particularly in the setting of gender affirming care, but not in general. But in the setting of gender affirming care, like testosterone, and you can think about some of the testosterone associated skin condition, acne being one of them, androgenic alopecia being another. And those are things that are very, very common in trans women who might be receiving estrogen or anti-androgen. Really talking about hair disorder has been the main priority because that has been creating a lot of problems for folks. And there's a lot of research that needs to be done in terms of defining other conditions that people have just traditionally have not put the energy into studying. So I appreciate your question.
Thank you. I think Dr. Dansky has a couple of questions that he wanted to.
Yeah, thank you so much. What just a tremendous talk, and I commend you on all your work. I actually kind of hope to follow up on that question a little bit, and I was wondering if you'd be willing to sort of speak to your experience as an academician. I know you said you had funding from NIAM, sort of what your experience has been like to apply for and obtain funding in this area. We often have a lot of trainees on the call, so.
Yeah, I think it's really important of a topic. I think fortunately, the NIH and NIAMS has a specific focus of understanding skin diseases in diverse population. And I think we really need to emphasize that because I think it would be simplistic for us to generalize, oh yeah, a trans man will just treat it the same as a cis man. And without knowing the nuances of how hormone interacts with someone's genetic factor, environmental factor, and the life that they live in and the contextual environment, it's really hard to answer a lot of these questions that we're all interested in. And so I think for me, it was fortunate that NIAM has a very explicit focus on diverse populations, on understanding skin diseases in diverse population. And the NIH also has several notice of special interest that encourages people to study this topic further and has administrative supplements that funds these studies. And so I've been very fortunate to be able to leverage that, but that's not guaranteed. And I think as dermatologists, really need to advocate for the fact that we need to learn more about these diverse populations. And particularly with changing political landscapes, I think it's particularly important for us to stand our ground and show that this is scientifically important, and this is important for our patient population.
Thanks. Maybe somewhat related to that, I like the slide that you have looking at sort of how common transgender persons are in the United States and the medical school education bit in relationship to diabetes and the other things we spend so much time talking about. And every time I see you talk, I come away feeling the exact same way, like, gosh, I wish I learned this as a medical student. Why am I just learning this now? And so I was wondering if you could comment either at Emory or more broadly, sort of what efforts are being made to introduce this earlier on in physician training.
Yeah, I think there are a lot of ongoing efforts. On the AAD level, the basic dermatology curriculum now has a module on LGBTQ dermatology, which is a great way for medical students or primary care physicians to start learning about this topic. I think this topic is also increasingly incorporated in dermatology residency curriculum. Certainly, it has been incorporated in various test prep material, as well as increasingly diversity is emphasized on the level of, say, the American Board of Dermatology. And so, not to make it all test related, but certainly this is something that I think is increasingly emphasized on various level of derm education in conjunction with other diversity related efforts. And so I hope that that's a really good sign, and I hope that these type of platforms really allow us to continue to expand LGBTQ dermatology educations. So thank you for inviting me to speak here.
Thanks, Dr. Yeung. We've got another question from Dr. Richmond. She asks, could you advise on the proper management of silicone injection reactions in patients who have reactivity? You mentioned Plaquenil. Are there any other agents that work?
Yeah, that's a great question. In fact, I don't know if there is really such a thing as optimal management. In fact, one of my students, Danielle Mustin, wrote a systematic review that was published earlier this year in JAD International, just to review all the management strategies that are out there for silicone granuloma. The things that worked better than others are, and again, these are all fairly low quality evidence, case report, case series level, are kind of related to either surgical excision if possible, but as you can see in our patient with fairly extensive silicone injection, that may not always be quite feasible, or may have very severe associated complications or deformations associated with that. In terms of medical treatment that people have tried systemic steroids, steroid injections, minocycline, hydroxychloroquine. Some people have also tried TNF inhibitors. There has not been a single randomized control trial in terms of thinking about whether something is working or not. And so given how common this is in the community, I think this is really ripe for additional research for us to think about how can we treat this. And I know that, for example, Dr. Stamsky, as a granulomatous disease expert, I think I might actually pick his brain about what he would think about in terms of future directions for granulomatous inflammation related to a foreign body such as silicone.
Yeah, thanks. I don't know that I have anything overly intelligent to say. I mean, I'm familiar with the literature that you are. I mean, we've been using JAK inhibitors and other inflammatory granulomatous disease. I'm not aware of them being used in this setting in particular, but I think how the silicone activates macrophages is probably a pathway that hasn't really been worked out and might give us some insight about how to treat these better. But infection is always a concern. So if you're immunosuppressing, I think it's especially with something like a JAK inhibitor, I think it's tricky because there's always some concern that there's an undetected infection.
Right, and particularly in this population, many of the patients live with HIV, and so the immunosuppression associated with JAK inhibitor will need to be additionally considered.
Thank you. So I think we've got time for one more question, and if people don't mind, I'll ask another one. And I think I might know the answer to this, but I'm going to ask anyway. Are there any clinical practice guidelines that we can use for even treating the common things like acne and hair loss in transgender patients? Please say yes.
No, there isn't. I would say right now, because there's so little research, oftentimes we're borrowing the evidence from cisgender folks and borrowing the literature that we get from, endogenous puberty and thinking about how that affects our patients. But really that literature is still developing. So we're not quite at the level of guideline development quite yet. But hopefully in the future.
Okay, thank you. Anything else, folks? Okay, well, thank you so much, Dr. Yeung, for your time and your insights. And we will let you go.
Thank you all so much. Have a wonderful day. Bye-bye.